Hello, everyone. Hope everyone is doing well. This is Mingus, your clinical instructor. I thought I will, kind of like help you guys to review. I know this is a very tough time. I wish you guys were on the clinic, but with the current situation, everything is all pretty much on hold. But meanwhile, I think we can kind of simulate some of the procedures. So today I have a presentation for esophagram. So let's take a look. So basically, esophagram is, as we all know, it is the study of the esophagus. So what are the some of the indication for the study? Some patient may feel there's something on their throat, chest pain, a chronic GERD. These are some of the indications for the study. And let's take a look at the whole preparation. So typically when the patient comes to our department, the technologists get a history, verify, just make sure you got the right person, birth dates, and everything that we do to verify that we have the right patient. And you want to go over the history, ask questions, kind of gather as much information as you can. So typically we do a chest X-ray first, AP. As you can see on this picture, that's the SCOT film. So the SCOT has to be done first. So you do a SCOT, and meanwhile, you do your preparation. So typically you will have Easy HD in our department, Georgetown. That's a thick barium. And then we have the Easy Pack, which is the tin. You want to have a straw ready. And this is the Easy Gas crystals if you're going to be using double contrast. You want to have two medicine cup, one empty and one with water. Okay, and also the barium tablet, it's a small one. And just in case also you want to have the 100 ml Omni Pack. So you want to have this all kind of ready. And so as soon as you take the chest X-ray, the AP, you show the radiologist, and the radiologist will pretty much review, and it will determine whether double contrast, single, or if he's going to be using, he or she, 100 ml Omni Pack. So depends on the the problem that the patient is having. If typically if the radiologist suspect any kind of like aspiration or perforation, he will typically use 100 ml Omni Pack. If he's looking for new growths, cancer, anything, that's typically double contrast. If you're just looking for the structure, any stenosis, narrowing as a result of GERD, that's going to be done tin barium. So the radiologist will decide. So once the radiologist decides whether double contrast, single contrast, the radiologist will come to the room, he will introduce himself, and this is the first position is LPO, as you can see. So this is a typical setup for the room. So you have the radiology technologist and the radiologist standing in front of the patient. So that's LPO. So before giving the contrast, um, the radiologist will give him a small amount of barium to drink, just a kind of like a very, very small. So the idea is that the first small is to make sure that there is no aspiration. So typically the patient will drink a small amount, and under the fluoro, the radiologist will watch if there's any problem swallowing. So let's say if there is an aspiration, so the study will stop at that point, and the radiologist will change the strategy. Most likely, if there's a suspect of aspiration, depending on how severe it is, so radiologist will change the approach. So there's a two type of aspiration. One is called aspiration, and the second one is called penetration. There's a word for it. I'll come back to it, but there's two types. So it depends. If it passes the vocal cord, that's the aspiration. Just remember it. Yeah, the first, if it passed the vocal cord, that is an aspiration. If it does not pass, that's penetration. So there's penetration and aspiration. So penetration is if it does not pass the vocal cord. If it passes, that's aspiration. So the aspiration is more severe because it's going all the way down. So aspiration is very, very dangerous because, as we know, if the barium contrast go into the lung, the patient can have a pneumonia. It can potentially also die as a result of it. So it's very, very important that to make sure that there's no aspiration before we continue the study. Okay, so assuming there's no aspiration or penetration, the first when the patient swallow, typically the radiologist will watch from the oropharynx all the way to the stomach, kind of observe without taking any picture. So on the second drink, the patient will have a multiple drink, and radiologist will take a series of pictures from oropharynx, the proximal and distal portion of the esophagus. As you can see, all the way to this is the distal part. This is the lower esophageal sphincter. Okay, so if it's a double contrast, this image is actually double contrast, as you can see. So if it's a double contrast, so you have two medicine cups. So on the first one, before you can even give him any barium, the first one is to give him the small amount of crystals that produces the gas. So you pour it into a 1 cup, and then three quarter of water you add to it, you mix it, and right away you give to the patient. And as soon as you drink it, you ask him not to burp. And then as soon as you swallow the crystals, and then you give them the thick barium, not the thin, the thick. So this is how the double contrast is done. So as you can see, it looks really nicely. What the crystals also does is it kind of inflates the esophagus. This is all the air that you can see, and it will have a beautiful contrast. So if the esophagus doesn't have any problem, pathology-wise, the walls should be nicely, almost like you drawing with a pencil. It's like really nice. If there's a problem, you will see it like a small raggedy areas. If there's any problem with like new growths, you will not see this nicely defined border. So as soon as the radiologist take the serous picture on LPO, so the table now is back to the supine, 0 degree. Okay, so from upright, as soon as the radiologist finish, we tilt the table to supine, 0 degree. Okay, so here you will turn the patient from 0 degree, you don't take any pictures, patient is turned to RAO, as you can see on the bottom. So on the RAO, the patient will hold the cup of barium. This is still on RAO position. So you put kind of like a tilted RAO, about 30 degree. So the patient with the left hand, he will hold the cup. Then you put the straw next to the patient. And per radiologist instruction, the radiologist will tell them, okay, drink 1 full mouse. So the patient will drink 1 full mouse, and radiologist will fluoro without taking a picture. He will follow from the oropharynx all the way to the LES until the contrast goes into the stomach. On the second picture, on the second phase, the patient will drink continuously, and the radiologist will take a series of pictures covering the entire esophagus from oropharynx all the way to the LES. Okay, so now let's go to the next. So this is the pictures that you see. You can see the proximal and also the distal. So the entire esophagus has to be covered. So on this picture, the radiologist will study the motility. There's a series of motility. We call it primary peristalsis and the secondary peristalsis. And if there's any problem with motility, the radiologist will take a close look. And also the contour of the esophagus. If there's any obstructions, this is the opportunity for radiologist study. So you can see really nice images. So typically on the when there is a nice peristalsis, the primary and the secondary, you can see them. It happens so rapidly, but you can see them. There's a primary and a secondary. And if there's any obstruction or if there is any problem, like achalasia. So in achalasia, what happens is the contrast goes all the way to the LES, and the LES it does not open. And you can literally see the contrast kind of like a sitting. So when that happens, there's a phase called tertiary peristalsis. It's almost like you can see almost like an earthquake on the esophagus, like almost like trying to open, but it will not open it. So that's the tertiary contraction is called, and that's not normal. Typically, this happens when the LES does not open. So after that, the patient is back to LPO. Okay, so now the patient is on this position. The radiologist is trying to look if there is any reflux. So that's part of the study. And as you can see on this image that I found very nicely demonstrated, you can see the patient. Typically, when you put in the LPO back to back to supine into RPO, so you make this a kind of like a quick movement from LPO back to supine to RPO. So if there's any problem, you can see the reflex. So as we all know, the LES, as soon as this contrast goes into the stomach, it's supposed to close. It's not supposed to open. But in this case, the ileus is very loose, and as a result, the contrast from the stomach is going back to the distal esophagus. So the next is the patient is in an upright position. So you know just make sure always patient safety. Sometimes some patient may feel a little bit dizzy, so make sure they can stand. What you want to do is always make sure that the foot is nicely standing. Kind of support the patient. Just make sure they don't fall down. If they cannot stand upright, you can also tilt a little bit, like depending, maybe 60 to 45. It can still give you a nice study. But this is like a really healthy patient, no problem. They can stand. You can put them upright, 90 degree. Okay, so here, this is where you give them the tablet, which is a barium tablet. The whole idea is to see if there's any narrowing, like a stenosis on the esophagus. A lot of times, if there's a problem on the esophagus, the tablet will not pass, and you can see it on the image. So what happened to the tablet if there is any stenosis or any narrowing? Well, it will dissolve by itself because it's basically made of barium, so it will dissolve by itself. So this pretty much will conclude the study, and then you just escort the patient to the waiting area. The radiologist, meanwhile, will pretty much review all the images just to make sure that he or she has all the images. If it's a resident, typically we'll go over with the attending just to make sure that everything is covered on the study. And if everything goes well, the radiologist will instruct you to discharge the patient, assuming this is an outpatient. If it's an inpatient, of course, you have to call the transport, and then they will take them back. So here I put some notes. What are some of the indications for the study? As I mentioned earlier, is reflux, difficult swallowing. Patient feels something stuck on their throat or chest area. Suspect of leak, like fistula. These are, basically the thing that concern and the reason for the study. As I mentioned earlier, if there is any suspect of a leak, you cannot use barium. So Omnipaque is used. What can we demonstrate by esophagram? Reflux, Barrett esophagus, achalasia, hiatal hernias, cancer. And I have some images that I want to show you. Here you can see kind of like a mild reflux. I have seen reflux that goes all the way to the oropharynx area. So the severity depends how wide this area is open. So this is typically with a patient with GERD. So when patients have a GERD, as you know, the acidity from the stomach goes back to the esophagus, mostly distal. So this area here are constantly being irritated by the content of the acid. This acid is so strong. It's the rugae, which are the lining for the stomach. The cells are designed in such a way to withstand the acidity of the gastric content. However, the cells that are located at the esophagus, they are not the same cells as the one in Ruge. So they are not really designed to withstand the acid of the stomach. It's a 1.5 to 3.5. It's very strong. So every time this acid goes back, this area gets so inflamed, irritated. So if this process continue throughout the years, the body is what it does is trying to kind of protect itself. So in the process, we'll replace the cells in a different cells that are located in the intestine. It's a different type of cells. So the body is trying to kind of recover by itself. So when the cells are replaced by different type of cells, not the squamous cells, this area becomes so rigid. So that rigidity also causes the LES to open more. So it's almost like the snowball effect. The more irritation, the more the body is trying to recover itself. In the process, will replace a different type of cell. So this area becomes so rigid, and it does not close properly. So what's going to happen is now you have this area becoming wider, and then you have more acid content going back to the esophagus. So if this process continue, now you have a condition called Barrett syndrome. I think I may have, let's see no, that's the achalasia. So the Barrett syndrome, as you can see on the image, let me draw a picture. You will see nice esophagus, but here you can see kind of like a rigid. This is what you see on the image. So you have a nice esophagus, nice contour. And here you have this kind of like a narrowing, rigid area. And as a result, this doesn't close very well. The LES is like almost, wide open. So every time patient has
the food content from the stomach, it will pretty much
swallowing,
go back all the way to the distal esophagus.
When I was taking history, he told me that sometimes he will have this content all the way to the mouth. So when he wakes up in the morning, he can feel like almost, he can taste it at his mouth. So that means this gastric is going all the way to the mouth. So it's very serious. So this Barrett syndrome is considered precancerous. So if this continue, the patient can have a cancer down the road. So having cancer in the esophagus is not it's very dangerous because the walls are very thin, and it can easily affect the aorta and other structures next. So it's not a good thing to have cancer. I mean, in generally, it's not a good thing to have cancer, but when you have a cancer in the esophagus, it can easily go to the nearby structures. This condition is called achalasia. So achalasia is a condition where the lower esophageal sphincter does not open. It's kind of like an opposite. So here you can see the contrast is pretty much sitting. So the LES here is not even opening. So this is where patient feels kind of like a chest pain. They feel like something is stuck. So this is you can see the picture nicely demonstrated. So if this condition becomes very, very chronic, after a while, the esophagus kind of stretches, overly stretch. And when it's overly stretched, what happens is that the peristaltic activity can can pretty much halt. So it does affect the nerves that control the peristalsis. Yeah, this is another image of achalasia. In radiology, there's a two term that they use. It's called a beak sign, B-E-A-K, almost like a beak, like a bird beak. So this is what they're referring. That's a beak sign, and also some radiologists I've seen them use the term rat tail. You can see you'll see structure like this towards the end. So this one's called the rat tail image. Almost like a rat tail. We can see on the image. This is a typical sign of achalasia. This condition is called esophageal varices, and this is due to the portal hypertension. So also in radiology, there's a term called rosary appearance, almost like a rosary. You can see on the image. Yeah, it's called a rosary appearance. So this is the type of sign that you see is due to the portal hypertension. There is a procedure called TIPS, T-I-P-P-S. It sometimes is done.
So the reason for the study is to alleviate the pressure from the portal vein, pretty much. So what this procedure does is, instead of the portal vein going to the liver, it overpasses, so it connects directly to the hepatic vein. So the hepatic vein goes directly into the heart, so almost like overpassing.
And if you create
so portal vein,
small road to the side,
instead of going to the liver, it overpasses and connects directly to the portal vein, and the portal vein takes the blood into the heart. So this is it's a very good technique, and it's done by the interventional radiologist.
This procedure is called
so they put a stent just to keep it open.
TIPSS, and it stands for transjugular intrahepatic portosystemic shunt. This is a hiatal hernia. As we know, the hernia is called hernia when you have the stomach. Any structure of the stomach past the diaphragm. So this is the diaphragm. You can see. So you can see the stomach is way in the chest area. So the stomach should not pass this line. This is the LES. So the stomach should be below this line. So every time the stomach goes into the diaphragm, then it's called the hiatal hernia. And I have seen the stomach where there's, the whole stomach is inside the chest area, past the diaphragm. So the severity really depends. You can see here the stomach is all the way in the fundus area.
This image shows diverticulosis, which is not very common, but we see a lot of cases. So the diverticulosis is merely the presence of the pouch, which is the weakening of the wall of the esophagus.
So diverticulosis is merely the presence of the pouch of the or the presence of diverticula. When the part, sometimes this can accumulate, like a food, anything, any content, and that can create, bacteria, and it can get really inflamed. So that's called diverticulitis. I think this will conclude the study. I hope you guys find this study helpful. If you have any questions, you can always